everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. Today, we're going to be talking about virtual reality, something that I just love. I think it's such a fascinating new technology, although it's really not new. It's been around for a while, but it's coming into maturity, I think. And our two guests today are Dr. Justin Barad. He's CEO and co-founder at OSO VR. And we also have Dr. Cory Calendine. He's chief of orthopedic surgery for Williamson Medical Center. Welcome, guys. Glad to have you here.
Thanks for having us.
Yeah, thanks, John.
Yeah, so before we dive in to the VR and everything you're doing, Justin, you want to kick us off? Tell us a little bit about Osso VR.
Yeah, so, I originally got my start in video game development, I play video games all the time. I wanted to create them. And I had a family member become very ill, and it just sort of changed the direction of my life. And I woke up one day wondering, maybe there's a way to use software and technology, not necessarily for entertainment, which is great, but to help people with medical problems. So I studied biomedical engineering in college with this goal to invent new healthcare technology, but I didn't know how to get started with invention. So I was kind of asking around for advice. It was a bit of a life crisis. And someone told me something that really sticks with me to this day. He said, Justin, if you want to invent something, you really need to understand the problem you're trying to solve first. And he thought that one of the best ways to understand medical problems was to be a doctor. So I took his advice in retrospect, maybe a little too literally, and ended up going to med school at UCLA. And then I stayed there to do my orthopedic surgery training and fellowship in pediatric orthopedics at Boston Children's Hospital. It was really during that experience that I witnessed firsthand one of the biggest problems we face today in healthcare, which is how we train and assess our healthcare professionals with procedures and surgery. And, I could go on and on about the challenges we have, but it really boils down to a few simple things. One is there's just too much to learn. We're being spread too thin. We've gone from French Laundry to Cheesecake Factory. Two is modern surgery, especially what Dr. Calendine does, which is highly complex robotic surgery, is much harder to learn. So the learning curve has gone from maybe a handful of cases to more like 50 to 100. And then finally, we lack a way to objectively assess technical skills. The only time I've really been formally assessed for my surgical ability, I was asked to play the board game Operation and remove some pieces without buzzing, which I did. And I'm proud of that, but that's kind of like where we're at right now. So I was seeing this firsthand, and I got involved in virtual reality very early because of my gaming background. I'm like, oh my God, what an incredible solution. You can use this anytime, anywhere, train on any procedure with your hands in a realistic way, get objective assessment, and train as a team or train people remotely. So came up with this concept for Osso VR and started in October 2016. And here we are today at 200 people trying to change the world with our mission and improve surgical delivery.
Yeah, that's pretty awesome. I've met a lot of doctors who have been in med school and wanted to be entrepreneurs, but I've never met someone who wanted to go to med school but had the entrepreneurial dream before that. So that's
I don't know if I'd recommend it. It's a long road.
That's a huge investment to understand a certain population. Dr. Calendine, how were you first introduced to VR? What was kind of your first foray into this? Are you a gamer too? Maybe we need to share our favorite games. I don't know. Go ahead.
Listen, I had Atari as a kid. Does that count?
Nintendo.
Oh,
I was
for
a big
sure.
Nintendo guy.
Justin's story there is so rich about, how he kind of was interested in gaming and then came to medicine. Man, I was all medicine. For a time I wanted to be like a garbage guy because they got to hold on to the truck. But very early on, I knew medicine was for me. And,
okay.
My dad was a preacher and, I was medicine, surgery. I was not the gamer. In fact, my dad claims that the local arcade was owned by the mafia. So he just didn't want to give me quarters to play games. So gaming was really not part of, certainly wasn't part of my medical training. This is all relatively new, but it really wasn't a part of my life. But Justin and I actually connected through one of the companies I work with. He already mentioned it. We do robotics, and in the robotic world, I'm talking about, for me, it's robotic hip and knee replacement. We have to train all these surgeons that aren't in training. They're doctors, they're out there doing real cases, but we're training them on new technology that's quite complex. And so that's how I met Justin, and he actually walked me through. I knew nothing of gaming. That's really my point, John. I did not come to this wanting to like gaming. In fact, I was kind of nervous about, man, am I going to like this? This is not really, what I'm used to, how real can it feel? And I was blown away. That's the reality. Justin walked me through how to turn it on. I mean, very simple stuff, but very quickly in virtual reality, because it feels so much like the world I do know in the operating room. Man, I was really taken by it. I've told this story a couple of times, John, but you'll probably appreciate it. I walk out of the room. My 11-year-old puts the headset on and starts doing a tibial nail, without instruction, and quite frankly, without permission to touch the stuff. So it's very intuitive, and that's not what I expected, because my background was not gaming at all.
Yeah, so we won't ask you your Candy Crush score, but to tell us, what is the advantage of this system, right, in using virtual reality versus, say, traditional surgical training, and how is it working for you?
Well, I think there's many. Justin will probably have some better framed thoughts about this. But for me, listen, surgeons, we all think we're busy, right? Surgeons are the worst of it. But the reality is we have to learn these new techniques, and we want to do it on our time. And I don't want to have to travel to do it, to be quite honest. So I need something that I can do anytime that's convenient for me, anywhere, and repetitive. We need the reps. We've known in surgery for years that the more cases you do, the better you get at it. And this is true for everything. I mean, where I take my car to get the oil changed is the guy who changes oil on that type of car, right? So we want specialists, we want professionalists to have the reps in. VR allows that, again, on the surgeon time, anywhere, and in a very realistic environment. So now that I've hacked that from a surgery standpoint, Justin, how do you frame it up?
Yeah, I think, it's a common question, and we're not really replacing anything. We're really making what we're already doing much more functional and data driven. So, when we're trying to learn, especially when we're out in practice, a newer procedure, or maybe one that we don't do regularly, there is very little ability to train in a hands-on way outside of on real people. But every now and then we do get the opportunity to go to a cadaveric lab where, you can practice and run through end-to-end on the technique. But the challenge is the learning curves of these cases are often like 50 to 100. And you're doing like rep 1 out of 50 or rep 1 out of 100. So the retention of that is going to be quite low. If you look at the adult learning literature, you're going to forget 90% of what you learned within a week. And by the time you're actually operating on a patient, it could be 6 months after that cadaver lab, especially if you're talking about getting you have to ship a robot in, and, you have to get it approved by your hospital. You have to find the right patient. So a lot has to take place. So, now you're operating on a person with a very complex device used one time 6 months ago with a learning curve of 100 cases. Like, how's that going to go? And this is so common in the industry. It's called one and done. It's such a horrific experience as a surgeon. You're like running around the room, the reps running around, people are Googling, and we're like, hey, this feels unsafe. Let's just stick to the older technology, when in fact, everyone was just undertrained. So how does VR get involved here? Well, you're not replacing that hands-on portion, which is still really important. You can in certain cases, but what you're doing is you're front loading the bulk of the training. So you're getting familiar with the workflow, you're getting familiar with troubleshooting complications, you're getting more efficient. And by the time you actually get to the course, you are much further along the learning curve. And we have published data that shows that people who train in VR are 300% more likely to complete a procedure without needing supervision, which is published in a journal called Core, or their performance scores went up 10 points or 230% when compared to training without virtual reality. So now when you come to train on a patient or in a hands-on lab, you're 2x better, 3x better than you were before, and you've gone from an introduction to a master class. Now you're just refining your knowledge, you're polishing those little bits and tips and tricks you can only really get from in-person training. And then on the tail end of this, if there's that big gap, you have now an ability to refresh. You don't have to wait 6 months and just hope it goes well on a patient. And then the other thing that I don't think we're talking about enough, and I used to just not really bring it up that much, but now it's becoming existential, is the staffing issues that we have, or training the team. So everyone always talks about us surgeons like we're superheroes. And I think we're pretty cool, but there are other people involved in our surgeries, and more so today with more modern complex technologies, where it's less of we're, golf players or tennis players. It's more like a soccer team or a symphony where everyone has their part to play, and it's almost equally important. one of the places I trained, if a circulator nurse that was trained in the procedure wasn't present, we would just cancel the case. And I know a lot of places that are similar to that for anterior hip replacement, Cory. And so now we're not only running in a situation where maybe you have specialized staff, but staff have quit in astonishing numbers. And so if you're lucky enough to actually have a case that has staffing, the staff often have never even done an orthopedic procedure or an interventional procedure. And like you're training them up right then and there, like 15 minutes before the case. And it's like not a great situation. So having this tool where you can rapidly in-service people unlocks the ability to continue delivering care for patients, which is a pretty astonishing problem right now.
Wow. That's interesting. And I think you've helped some, to understand that this doesn't replace, it augments and enhances, a lot of the current techniques. But I imagine there's still a lot of skeptics out there. They're like, is VR really capable of training, right? I mean, it feels like, you've probably heard this question 1,000 times. What does it take to really get buy-in? And are there limitations to the technology that people should know about, Justin?
Well, I mean, I'd love to get Cory's opinion, but yeah, I mean, I think one is we have, 5 or 6 peer-reviewed studies at this point that support the technology in a astonishing way. Like, it's like, not only does it work well, it works really well, like, more than you usually see in these types of studies.
Mm-hmm.
But I always say something, I say, data's not enough.
Mm-hmm.
Like, it's great that something works really well, but you still have to get people to use it. And we're both very conservative in medicine, but we're also really busy, and it's hard to get our attention or to drive behavior change. So you got to give people a reason beyond it works. And so that reason for us is kind of a couple of things. One is a culture of positivity and excitement in a time where we're really not having a lot of fun in healthcare these days.
Yep.
It's still amazing to do surgery and stuff, but this has been a rough few years, to put it lightly.
Yep.
And the other is we bring a level of visual fidelity to this platform that's not only clinically accurate, but is inspiring and jaw-dropping, to try and show people something they've never seen before, to get their attention and then keep them coming back. And that has been unbelievably successful for us. And when people see OSO or try OSO's experience, they're not the same afterwards in a positive way, because it's similar to what Dr. Calendine says, just like, I've never done anything like that. I've never seen anything like that. And in healthcare, we don't get a lot of that these days. It feels like the promise of technology has passed us by. We've gotten sort of the hand-me-downs of the EMR, which everyone, I don't want to like badmouth EMRs, but they're not super well loved, I guess I'll put it politely. I almost threw a computer out a window once. I'm sure a lot of people have a similar experience. And it feels like we're just getting the crappy technology while the whole world seems amazing and is getting all these incredible things. And this with OSO, it's like, hey, it's our turn now. We're getting polish, attention, positivity, excitement. And that is part of how we can drive behavior change in health and get people to do things differently. Even when it just unambiguously works, it's still a challenge.
Yeah. Go ahead, Cory.
Well, yeah, I mean, I was just going to kind of highlight as Justin was talking. I mean, these graphics, the surgical world that OSO has created in these spaces are just so real, like high fidelity type of experiences that really draw you to them. I've mentioned before, I had a partner who's, I mean, let's say a little bit older, who had no experience in gaming, much like myself. And I said, man, you should try this, like jump in this robotic space and see. And he's like, oh, this is, this, John, like what you were saying, skeptic, right? I mean, come on, it's a game, like this can't be real. So anyway, he jumps in there and again, very quickly takes over. He's a surgeon, so he's very dominant and, wants to get it done right away. So he's in the space, 7-8 minutes, loves what he's doing, thinks it's so cool. He's getting his, proficiency scores, you can actually track your progress, right? So he's getting some immediate feedback, which he's loving, because again, a very competitive heart of a surgeon. Anyway, it's time for him to go do an actual case. And he says, Cory, I'm done. And he goes to put these handles that we use for this haptic feedback, put these handles down on the OR table that's actually not there. And so he's been in the space for 7 minutes and goes to place these handles that do exist on a table that clearly does not exist. But after 7 minutes, he believes he's in there. He breaks one of the 2 handles. I replaced it, Justin. Don't worry. But the reality is, it has to be this high truth, high fidelity, beautiful place in order to kind of give you that simulation, at least from a surgeon's perspective.
Yeah, it's interesting to think about because we've had this in the EHR world that Justin loves, yeah, that all doctors love. No, but we've seen this right with things like clinical decision support, and I've heard people argue that like not using some of the clinical decision support or different things is and probably could be malpractice for many situations. Is that kind of what's happening, or do you think that's what's going to happen with the research, that if we're not using technologies like this to get the repetition, that it could be seen as a lower quality education, or kind of is this a standard practice for surgical training and assessment? What do you think? Go ahead, Dr. Calendine.
Well, I mean, it has real potential for us to be able to, in a very safe environment away from the patients, track our own proficiencies, right, and competencies. Nobody wants to be more competent or proficient or good at what they do than a surgeon, right? I mean, we carry that with us. And so I think eventually, as this expands, and I say, as it expands, it's kind of like wildfire right now. It seems like everybody is talking about it. All the major industries and, even academic centers, want to leverage this type of technology. So, but anyway, as it takes off, I think there's real potential for us to, prove our efficiencies and stay up to date. And who knows, I think it could very well be a standard for proficiency, because again, it's in a safe environment. Justin, what do you think? Do you see it going that far?
Yeah, I mean, I think you really have to be careful how you structure these things, and taking into account all the different stakeholders. I think you can get the results you want of improved sort of, and robotics is very similar, right? Or navigation, where the promise is not necessarily that in general the outcomes are better, although people like me and Cory think they are, but it's more that it creates more consistency, more consistent results. So these outliers of where things go wildly off the rails, it does an amazing job of reining that in. And so similarly, it's like, we don't want to punish people for like, hey, your VR performance is poor, but like, hey, like, let's implement standards of, if you're going to get board certified, like you need this VR minimum, or, to be able to do certain cases, like we'd want to see certain VR minimums, or frame it as a bonus. Like, for example, for our malpractice premiums, like if you do VR, you can get a discount. If you don't do it, we're not going to arrest you or anything like that, but it's a bonus. It's an additive. You're not creating risk for people, which is definitely going to, it's just, everything's so hard. Like adding something like punitive like that, I don't think I would react well as a surgeon or other healthcare professionals. So you really need to understand, and this is the hardest part of healthcare innovation, is like really understanding the stakeholders. They're sort of not only their rational incentives, but their emotional ones as well. So that you can make sure you're just sort of aligning all of that as best as you can.
Interesting. Yeah, I mean, I don't think we're going to see VR training scores on Yelp any day soon, but
you may see certifications, right? Like once again, it's just like value add. It's like, hey, I have done like AO advanced course in VR or something like that, right? Or I've done some sort of joint replacement, like I've done a Dr. Calendine saber to the bone VR training experience, and my patients can see that. And it's not, I'm not getting a score. I'm not being told like I'm a bad doctor to people, but it's like, hey, I've done a little extra work. I've done extra effort to prove to you that you are going to get some kind of minimum quality standard that people really are excited about.
Well, it seems like you're addressing the problem that we hear about all the time, which is in value-based care, we want to send you to the person who's done 1,000 surgeries, not the person who's done 5. And you're kind of addressing that problem. Well, if you've only done 5, you haven't had the repetitions, to Cory's point, right? Is that kind of where it is? Or can a doctor who's done, if they're well-versed in doing the actual surgery, can they still benefit from VR? Or, how does that play out? Have you studied that at all?
Yeah, I mean, I think there are always going to be situations, even for surgeries, where you are very high volume. And Cory, please weigh in on this, because operating way more than I am. But we encounter unusual anatomy or pathology all the time. So it's like the same surgery, but maybe it's like a unstable knee or valgus knee or something like that. In the case of arthroplasty or dysplastic hip, which not all hip replacement surgeons are dealing with typically, like a younger patient. Or so there's always, even if you're a very experienced high volume surgery, there's always a situation where that might be helpful. But certainly for someone who is a bit lower volume, this is a huge opportunity. And it's the world we live in, and just this thing that we've accepted that, hey, in certain areas of the world, in this country, that you're just not going to have as good of a result because, they only do the surgery 2 to 5 times a year.
Right.
But now we can actually do something about that, which is great for us because we never want to put people at risk. It's the worst feeling in the world. And obviously it's great for our patients too, to be able to get closer to that kind of high volume tertiary care level at the community level.
Yeah.
Well, that's so interesting, Justin. And I think you said it well. I mean, like here, where I live, you can't throw a stone and hit multiple orthopedic surgeons that do, high complex joint replacement. That's a privilege that we have just in my little area. But what about underserved areas? And obviously I know Justin and his team are putting a lot of thought into, outside the US. They use a term that I love about democratizing access to the very best in surgical care. Like we kind of forget that. We kind of act like, well, this is just the famous guy at the big US institution. Well, yeah, that's one thing, but how can we deliver excellence in surgical care to everyone, right? That geographically can't get to these centers of excellence. I think that's a really exciting opportunity here.
And I think it's not just, even these high volume people who are operating and doing these surgeries all the time. There's another problem we're not really talking about. And I call it the sort of exploration problem, where there has been an abundant proliferation of new technologies and new surgical techniques. And it has become, from our perspective, overwhelming. There are like too many options now.
Interesting.
And so how do we even know what's out there in the first place? Like that's like a challenge enough as it is. And a big part of that in sort of the pre-pandemic world was going to in-person conferences, and those are coming back, but it's not a great way to really have consistent understanding of the evolution of our technological landscape in surgery, because you can only see so much walk around the show floor hungover after hanging out with some of your friends, which I hear some people do. I don't. But the other element is, say you do want to use one of these new technology, your patients are asking for it. Well, now you need to learn about it. And so you may be a very high volume, very skilled surgeon, but now you're trying to learn a new procedure. You're often having to start from scratch anyways. And that's often right now a bridge too far for most people. Maybe they'll go to a course and then realize, yeah, it's just too much. I'm not going to use this newer technology that my patients would benefit from or they really want. So we can allow people to explore immediately from the convenience of their own home all of these different techniques and technologies, choose what's best for them in their practice, and then rapidly work their way up the learning curve so they could bring it to their patients quickly and increase access, like Cory was talking about.
Yeah, your point about understanding the new techniques reminds me of Up to Date and what they did with research, right? Bringing the research to it, and how do you discover the new research? It's interesting to think about you doing that for new surgical techniques and bringing those to bear and illustrating them. That's fascinating. So Justin, as we kind of wrap up, where do you see VR and the metaverse? I think it's I don't know. It doesn't feel like the right term for this discussion. And Facebook's trying to make that popular, obviously, but where is all of this going in healthcare, and what are some of the big opportunities still out there?
Well, I think, immersive technologies in healthcare have huge potential. Virtual reality has all sorts of, training, I think, is the biggest use case. I'm a little biased. And then there's some therapeutic applications, which are unbelievable, and rehab. And then there's also just the whole field of augmented reality, which has a lot of different but interesting use cases as well. I think obviously I have the most insight on like where this is all going for us. And this really does seem like it's being rapidly adopted as a standard for not just doctors, but all healthcare professionals. So most of us do some sort of technical aspect to our jobs, whether we're putting an IV or doing complex robotic surgery. And so having the ability to train, to maintain our proficiency, to create standardization, to have leading indicators rather than lagging indicators. Let me just end on one more example. Like if something goes wrong in a surgery, we will talk about it afterwards in a morbidity and mortality conference, M&M, be like, hey, tough cookies that this one person is paralyzed, but like, let's figure out what to do better the next time. But wouldn't it be better to going into the surgery to know, hey, here are the elements we can improve beforehand and optimize the outcome so we don't run into this situation in the first place? And training's part of that. That's not everything. That's also decision report and risk stratification and, patient routing and things like that. But this is a very important element because right now we are in a black box. We don't know what the inputs are. We're just hoping it goes okay, and then we're fixing the problems after the fact. So I think that every healthcare professional that does procedures will have a virtual reality headset, ideally with OSO. They'll be training and assessing themselves on any procedure they need to on demand if necessary. And we will also have a centralized repository of this proficiency data that we can use to improve healthcare delivery for everyone around the world in a way that is very rarely seen. And I find very exciting.
Yeah, that's great. Cory, anything you'd add?
Well, I mean, I was going to come back to your comment about the metaverse. You know, as I understand the metaverse, it's about connecting to people in the virtual space, and we've hit on so many cool things that I wouldn't want to take away from anything that Justin just said about where we're going. But I think this is about connection. You know, we talk about the collaborative mode and bringing surgeons together across the country in this virtual space. Justin already mentioned, you know, training your staff in the virtual world. I think the reality is we have to understand that this virtual world, this artificial world, and you mentioned Facebook pushing the whole thing, is about connection. Right? It's about connection. And I really do think surgeons are dedicated to always improving, always learning, and always growing. So I think connection's the key to that. And I think VR will be essential to that going forward.
Yeah. Well, this is great. I appreciate you all taking the time to share. It gave me some new insights and perspectives on the VR training side. I think that is a fascinating side. You know, it is interesting. I heard another example with a patient where it made the patient comfortable with the procedure that was coming with a VR solution. So, you know, I'll throw that one out there as well, just as a little cherry on top of where all this is headed. So thanks so much, guys. Appreciate you sharing your insights and perspectives. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, guys.
Thanks, John.
Thanks, John. Enjoyed it.